Now we move on to the next talk, that is OCT in glaucoma. As you know, initially the visual field interpretation is the most important part in treating, when to treat a glaucoma, but you know that 30% of the visual field should be affected to get a positive finding in the visual field. When OCT comes, the term, the pre-perimetric glaucoma came. So the importance of OCT is very important in treatment of glaucoma in the current scenario. Over to Dr. Jayasree, who is the Senior Consultant at iVision Hospital, Thrissur.
Thank you. Thank you, KSOS and Mallika Madam, for the opportunity. So the presentation is on OCT in glaucoma. So OCT is useful in multiple aspects of glaucoma, mainly the optic nerve head and OCT evaluation of the RNFL. And DDS segment also, the OCT is important, especially in the angle assessment. And OCT angiography is also important to identify the pathology of vascular supply of the optic nerve head and the choroidal supply also. And coming to the proper heading of optic nerve head and RNFL, pre-perimetric glaucoma, as madam has just mentioned, up to 4 years before the earliest visual field defects happens, RNFL defects tend to happen, and that is where we can earlier catch this glaucoma. It is especially useful in suspicious optic disc with normal visual fields. Here what we see is there is a suspicious disc, and if you ask me, there is a suspicious visual field defect. So to make sure whether there is an RNFL defect or whether it is glaucoma, we do an RNFL analysis, and then you see that there is an infratemporal RNFL defect, and then your diagnosis is really clear here. So it is very important to correctly identify and interpret the OCT printout. Here I am going to interpret a Cirrus HD OCT optic nerve head and RNFL, and most of the other RNFL and other printouts are analyzed in a similar way. So it has 9 parts. So why do you have to systematically interpret an OCT? It is, first one, not to miss the small details, and it is important in final decision making. You have to identify artifacts and anatomical variation so that misdiagnosis is avoided. So these are the 9 parts that you have to remember. It is very important not to just look at these 2 diagrams, these 2 pie charts here and diagnose glaucoma. That is not sufficient. So there is a color coding, as you can all see, and this color scale is a comparison of the thickness of an individual's measurement against the normative database. Green is when you lie between 9 to 95%, yellow is between 5 to 1%, and if you fall below that 1%, that is when it is 1%. If you are not gradable, it is in gray, and if your thickness is more, it is white. So patient data is always important, signal strength most important, so it comes in the first portion, and date of birth most important because it is against this age match that every normative data base is compared against. Signal strength, so beyond certain signal strength, it is not very useful to compare that data. So multiple machines have multiple signal strength, and beyond which data it is acceptable. Look at these values, more than 6 in Cirrus OCT. Spectralis, the quality score has to be more than or equal to 15, and OptoView, the SSI is more than or equal to 30. So coming to this key parameter, the key parameters are given side by side, and you can compare with both the eyes. And this is again, you can see, compared to the normative database and is color coded. RNFL thickness map is something that is exclusive for this Cirrus OCT machine, and this is what you call falsely color coded. This raw RNFL thickness data is given. What you see as cool colors are where the RNFL is thin, and the warm colors are where the RNFL is thick. This is not compared to the normal database. If you see black areas in this RNFL thickness map, those are the areas which are not used for data analysis. If you see, this is the neuroretinal rim thickness plot. What you see here is in the TSN90 configuration, this neuroretinal rim is measured between the Brooks membrane opening, that is the border of the optic nerve head, to the border of the optic cup. And you can see that this again is age and disc size match, and is compared with the normative database. Everywhere the data are given together, or because the symmetry can be analyzed. It is very important always to look for the symmetry of the eyes in glaucoma and also the size of the disc. RNFL deviation map is something that is very important. The measured RNFL thickness is shown, and you can see these yellow areas. This is less than 5%. If it comes in red, this is less than 1%. Where is this RNFL thickness measured around the optic disc? It is at 3.46 millimeter. This circle comes around 3.46 from the center of the disc. You can actually calculate, you can actually move this manually, this circle manually, but your the normative database comes for 3.46 millimeter value only. The RNFL thickness Tissen plot is seen like this. The RNFL thickness at each location along the calculation circle. If you open up that circle and stretch it on an x-axis, this is how it looks like, and you have double hump pattern here, and that is because the superior and the inferior RNFL is thicker than the nasal and the temporal. It is very useful in detecting the earliest thickening. So if you always look for this tracing, if there is a localized thinning here, that is more indicative of a RNFL thinning localized. These summaries of the RNFL thickness are given in the quadrants and the sectors here. Again, these are the B scans that was already told, and this is to make sure that the configuration is appropriate. And this is the OCT image calculation circle, just to make sure that there are no PVDs which are causing green disease. Green disease I will come to later. So this is how a normal and an abnormal, normal and a glaucomatous this OCT looks like. This is glaucomatous where you have cooler colors, where the key parameters you can see are in red, and you can see the RNFL deviation map showing red colors there. The NRR thickness has come down, RNFL defects, RNFL thickness has come down, the pie diagrams are also affected. So these many changes you can see in a glaucomatous OCT. So many changes have to be looked for. Yes, GCC is very important in glaucoma because very low variability. GCC is something that is getting affected even earlier than RNFL. It is important to image macula for glaucoma because it has low variability, less prone to artifacts and anatomical variation. But one limitation is that glaucoma is a disease of elderly, and when you become elderly, they can also have macular diseases, so that can affect. So GCC also you can interpret based on the similar lines. You have this thickness map here, deviation maps, and these parameters also follows this color coding and the age matching. Coming to normative data, it is the axial length that is covered in normative data is between -12 diopter and plus 6D, and axial length is from length 22 to 28 millimeter, and beyond this, the highly myopic and hyperopic are flagged as abnormal. You have to see this age group. Less than 18 is not there in the normative database, and Indian eyes are not much studied in other type of SDOCTs and all. So what you see, if the patient's age is less than 18, the type of OCT printout that you get is not with this color coding that you see here, but without a color coding. But is it still useful? Yes, it is still useful because you can use this same OCT to compare the progression of the patient, even if he is less than 18. The same patient can be compared for progression with his own OCT. Are there any limitations of OCT imaging? Yes, because it needs clear media for good quality scans, cataract, corneal opacities, vitreous hemorrhages, and all this can lead to misinterpretations. Highly myopic eyes have more issues with that because poor quality imaging can be the segmentation errors, dissimilar reference database. So the alignment can be completely different. The calculation circle, that 3.46 millimeter calculation circle that we have taken, all those could be at TETOS. What is something very important is called as floor effect. If the glaucoma is very advanced, OCT becomes very less useful, especially beyond the HFA of -10 to -15 decibel. Tissues other than the RGC axons also contribute to RNFL thickness. That basic tissues does not die off, so that is the reason why you still have floor effect. RNFL thickness gets flat at 30 microns, and if your RNFL thickness goes beyond 30 microns, if it falls less than 30 microns, then that is a false reading. So red disease is something when you have false positive diagnosis. If there is no disease and the OCT machine finds out disease, that is red disease. If there is disease and the machine says false negative diagnosis, that is what is called as a green disease. So red disease usually happens in myopia. This is an example of green disease. Actually there is disease here, but because of averaging, that disease is not seen. So cataract leads to RNFL, gross RNFL thickening. So these are examples of red diseases, abnormalities, media opacities. Here there is a V's ring that is producing black spots which cannot be used. This is a myelinated nerve fiber. The calculation circle is wrongly found out here. Hemorrhage, which is found as a red area, which is thickened area. You can see that RNFL is. So we cannot use interchangeably. So the points to take home are: image acquisition with dilated pupil is always better. Allow the patient to blink and apply lubricants because signal strength is very important. Pay attention to scan quality before interpreting. Systematic approach, always come from top to bottom. Combining RNFL macula and optic nerve head parameters improves the diagnostic performance. Always clinically correlate with the HFI. Sequential OCT is important in progression analysis. SD OCT machines have similar diagnostic abilities but not interchangeable. Thank you.